So axillary surgery after neoadjuvant chemotherapy is not that much different from the upfront surgery setting. Sentinel lymph node biopsy is standard care in clinically node negative patients. In patients who have clinically node positive breast cancer and a good radiological response to neoadjuvant chemotherapy, you can also use the sentinel lymph node procedure, or you can clip the node and localize it selectively with use of modern imaging. And then you can combine the two, then you have targeted axillary dissections. So any one of those more limited targeted procedures that determine nodal PCR can be used to omit axillary dissection. This is considered evidence-based. There are several series that showed the same thing, that it's safe to do so, excellent outcomes without axillary dissection. Now it becomes more challenging when you have residual disease. Standard of care for a long time has been considered axillary dissection. We now have an increasing body of observational evidence that suggests that it's safe to omit axillary dissection in selected patients with residual disease. We have some real-world data from the National Cancer Database that suggests that this is the case in patients with only one positive node left and luminal biology. And we have the large real-world OPBC studies that showed that many patients with residual isolated tumor cells can be safely spared axillary dissection. We will report in about 2 weeks the results of the MicroNAC study, where we include 1,500 patients with residual micrometastatic disease. I cannot disclose the results quite yet, but I can say that there will be more evidence toward de-escalation in selected patients. And now we're kicking off for the macroNAC study, where we try to collect as many patients with residual macrometastatic disease as possible, so we can analyze the association of dissection with recurrence by subtype and by volume.